Okay, fine. Now you can start.
Good morning, everyone. Today, the seminar topic for me is tuberculosis. So, tuberculosis is a disease caused by bacteria called Mycobacterium tuberculosis. The bacteria usually attacks the lung, but they can also damage other parts of the body. So, usually TB spreads to the air when a person with TB of the lungs or throat coughs, sneezes, or talks. So, tuberculosis, it can produce a silent or latent infection as well as progressive active disease. So globally, 2 billion people were infected. It was previous records, and roughly 2 million people die from TB each year. So in 1993, the WHO declared a TB as a global emergency when the TB cases were crossing its limit. So the burden of TB in many countries is due to the co-infection with the HIV, that is human immunodeficiency virus, as well as in 2006, the majorly the multi-drug resistant what TB outbreaks was occurred, and in 2006 it was first reported. So etiology of the TB is TB is caused by tubercle bacilli, which belong to genus Mycobacterium. So they form a large group with the only three relative obligates, which forms as a Mycobacterium tuberculosis complex, which includes Mycobacterium tuberculosis, Mycobacterium bovis, and Mycobacterium africanum. So they form a Mycobacterium tuberculosis complex, and they are majorly responsible for the TB in humans. So according to UK data in 2008, so uh, in the survey, they got the report that Mycobacterium tuberculosis was 99% was Mycobacterium tuberculosis in the confirmed case, and bovis was 0.4%, and Africanum was 0.5%. So other Mycobacterium species includes like so there are other 15 Mycobacterium species, what pathogenic bacteria which are pathogenic to humans and causes pulmonary disease. So they have been found in soil, milk, water, and they're also referred as atypical Mycobacterium. There is also Mycobacterium leprae, which causes disease called leprosy. So pathogenesis. So tissue changes in the tuberculosis are not result of any exotoxin or endotoxin, but are instead the result of host response to the organism, which are due to the development of delayed type of hypersensitivity, type 4 hypersensitivity, and immunity of the host. Both these host response develop as a consequence of several lipids present in the microorganisms. They are mycocytes and glycolipids. Mycocytes, such as cold factor, are essential for the growth and virulence of the organisms, that is mycobacterium in the animals, as well as glycolipids like WAX-D acts as an adjuvant acting along with the tubercular proteins. So hypersensitivity and immunity are closely related, and they are initiated through CD4 plus T lymphocytes sensitized against specific antigens in tuberculin, that is cell mediated immunity. As a result of this sensitization, lymphokines are released from T cells, which induces the increased microbicidal activity of the macrophages. So, like inhalation of the Mycobacterium tuberculosis causes the phagocytosis of the bacilli. So, inflammatory cell recruitment. So, its alveoli macrophages secretes interleukin 12 and interleukin 18, and interferon gamma induces the bacterial killing. Tumor necrosis factor alpha is essential in the growth of Mycobacterium tuberculosis and granuloma formation. The control of the mycobacterium growth by the stopping the MTB proliferation, chronic cytokine stimulation. Granuloma is formed by several cells recruited to the lungs inside infected cells. So in the macrophages, infected macrophages contain the MTB preventing their spread. After this post primary tuberculosis, Mycobacterium persistence is associated to a failure in the immune surveillance. This disease may be reactivated and damage of the nearby bronchi occurs, and the spreading of the MTB to the other areas of lungs are induced. The incubation period of mycobacterium is
Bhavith, in between, no, you can
yes,
pick someone name and ask some very basic, simple question just to ensure that they are listening you, because you don't know whether they are listening you or not. Okay, you can always do that.
okay, sir. Okay. So is a incubation period is from ranges from 2 to 10 weeks with a demonstrable primary lesions of the significant tuberculin reaction. So latent infection may persist for a lifetime. So HIV infection appears to shorten the interval of the development of clinically apparent TB. So usually latent infection, the chance of it getting activated in lifetime is 10%, but if the infection if the patient is HIV positive, then the chance of the latent infection getting into active disease is 10% every year. The transmission usually pulmonary TB is a disease of respiratory transmission, and patients who are who has active disease expel them into air by coughing, sneezing, shouting, or any other way. So they form a droplet nuclei in the air, and this each droplet nuclei contains like one to three organisms. Okay, sir.
Go ahead, Bhavith.
Started.
Yeah.
Uh, Transmission. So the MTB, that is Mycobacterium tubercular, carved or excelled by an active case, they remains in the air. If, for example, a family member, anyone gets, uh, they inhale that droplets, then there's a chance of not phagocytosed. There's or else they get phagocytosed by alveolar microphages, but they fail to establish infection. But if the organism level is like less, number is less, then they get converted into latent infection. The bacteria lives inside the granulomas. So otherwise, if they directly transform into active disease with the major symptoms like weight loss and the fever, cough, and this cycle repeats. Can anyone say the risk factor of tuberculosis?
HIV positive.
Hello?
HIV positive.
Uh, any other?
CRF, chronic renal failure.
Okay.
Diabetes.
Okay.
Injecting drug users.
Yeah. Okay. Any other? Okay. Thank you. So the risk factors are HIV, patient being HIV positive, any the drug like drug abuses which we uses injections, then solid organ transplantations like jejunal bypass or gastrectomy, hematological malignancy like leukemia and lymphomas, then chronic renal failure or receiving hemodialysis, receiving an anti tumor necrosis factor alpha treatment, and silicosis. So, can anyone say what is silicosis? Mahesh.
It's a long lung fibrosis.
The persons who work in factories like asbestos, they'll get silicosis. Inhalation of silica.
Yeah. Sorry.
The persons who work in asbestos industries.
Okay. So, like silicosis means it's a lung fibrosis due to the intake of silicas and all. Okay, the classification based on anatomical site of disease. It can be classified as pulmonary tuberculosis and extrapulmonary tuberculosis. So as it says, the pulmonary tuberculosis means it's on the lungs and the larynx part. So it refers to the microbial confirmed or clinically diagnosed case of involving the lung parenchyma or the tracheobronchial trees. So in extrapulmonary TBs or other than the lungs, such as lymph nodes, intestines, joint and bones, then pericardium, then meninges, etc. The clinical presentation of the pulmonary TB, the signs and symptoms, patient typically presents with the weight loss, fatigue, a productive cough, fever, and night sweat, and frank hemoptysis. Then physical examination shows dullness to the chest percussion rails and increased vocal parameters are observed frequently on osculation. Then the laboratory test, they shows the elevated levels of white blood cell count with the lymphocyte prominence. Then chest radiographs, they show the patchy or nodular infiltrates, the apical areas of the upper lobes or the superior segments of the lower lobes. Then cavitation that may show air fluids such as levels as the infection progresses here. So here you can see the difference between the two diagrams. There, say in the the left diagram, they shows the what to say before drug therapy. There is like some cloudy thing out there. I hope you can see that. Then you can see the right one with the
There is a way
there is
to
a
identify TB and pneumonia in X-ray. Okay, do you know that? If there is a patch, okay, if there is a patch like appearance, we say it is pneumonia. But in case of TB, you will see a cavity, a clear-cut cavity. You will see in TB. So this is a way to identify TB from the X-ray. Okay, so if there is any kind of cavity, whether it's small or big, that indicates tuberculosis. But if there is a patch, that points towards pneumonia.
okay. Then coming to the diagnosis, so major skin testing, that is tuberculin testing is done. This is the most widely used screening method for the tuberculosis infection, uh, and which uses the purified protein derivatives (PPD). The Mantox method of PPD administration consists of intracutaneous injection of the PPD containing 5 tuberculin units. The test is read to 48 to 72 hours after injection by measuring the diameter of the zone of induration. So some patient may exhibit positive tests 1 week after an initial negative test. This is referred as a booster effect. Then quantiferon or TB gold test. This measures the release of uh, interferon gamma in whole blood. This test can provide a diagnosis of even the latent TB infection, which doesn't show any symptoms within hours instead of 2 to 3 days required for traditional PPD skin test. So quantiferon testing does not require a return visit by the patient to the clinic for reading the PPD skin test, making it more convenient for the patient. Then the additional testings are like for patients unable to expectorate or sputum induction. Okay, the patient who are unable to expectorate, sputum induction with aerolized hypertonic saline is done to produce the diagnostic sample. Then bronchoscopy or aspiration of the gastric fluid via nasogastric tube may be attempted to in selected patients. Then for patients with suspected extrapulmonary TB, samples of draining fluids, biopsy of the infected site can be attempted. So blood cultures also really they're positive, especially in AIDS patient. Okay, the treatment, the goals of the outcome is rapid identification of new TB case, then initiation of specific anti-tuberculosis treatment ASAP, then a prompt resolution of the signs and symptoms of the disease, then achievement of non-infectious stage in the patient, then setting their isolation, then making the patient improve their adherence to the treatment regimen, then a cure of the patient as quickly as possible. General treatment is at least 6 months. Of the pharmacological therapy, uh, treating the active pulmonary TB disease. So the first line anti-tuberculosis agents which are used are rifampicin, isoniazid, then ethambutol and pyrazinamide. So rifampicins, they're present in capsules, liquid injection for infusions. And then the capsules of 150 mg and 300 mg is available. Then the dosage is like in adults, daily it's 450 mg per kg if the weight of the patient is less than 50 kg, and 600 mg if more than 50 kg. Then intermittent doses are 15 mg per kg. The child dose is 10 mg per kg, and the child intermittent dose is 15 mg per kg.
Yes, Bhavith, what again? Bhavith?